Hey guys, it's Marshall with PhysioU. I'm here with Kristen, and for Mentoring Minutes today, we're going to look at dorsiflexion and how a lack of dorsiflexion can change kinematics up the chain, especially with some functional tests. The first one we're going to look at is jumping off a step, so a vertical depth jump. So go ahead, jump off. Good. And we want to look at that from two angles. From a side view, we're looking at knee flexion, and as you can see there, people that lack dorsiflexion, studies suggest that there's a lack of knee flexion, so you have a decrease in shock absorption during that landing. From the frontal view, or from the front view, right, go ahead and hop off that step, jump as high as you can and land. Right? When we look from that view, studies show that when people lack dorsiflexion, there's an increased valgus force and adduction introtation moment at the knee. Again, if we don't have the ability to move anteriorly at our shin, our knees are going to make up for it. Another functional test to look at is a squat. So go ahead and squat down, right? And without cueing them at all, we can see that her knees dive in. And studies show that when you lack dorsiflexion, again, your tibia is trying to go forward, and so instead it's going to go internally rotate. However, if we put patients on a wedge and have them squat down again, right, without even cueing them to keep their knees out, studies show that if they lack dorsiflexion, automatically there's an improvement in the alignment. Lastly, we'll look at a step down. All right, so go ahead and keep this foot on the stool and step down with your right. And again, we're looking at kinematics of this left leg, and as you saw there, you saw a increased valgus intra-rotation force. All right. If we stick a wedge under that leg, and again, go ahead and do the same thing. Go ahead and step down. Okay. Studies show that there's an improvement in lower leg alignment when patients lack dorsiflexion, and you put them on a wedge. When we assess dorsiflexion, a great test is to use the dorsiflexion lunge test or the NeedaWall test. Just go ahead and put your hands on the table, and then keeping this heel down, lunge forward. This heel can come up. Okay? And we're going to measure using a goniometer or an inclinometer. Ideal is 40 degrees. As you can see here, she's limited. And studies suggest that a lack of dorsiflexion with this test is related to patellar tendonitis, Achilles tendonitis, chronic instability, lots of pathologies when you don't have that mobility there. Another way we assess for a lack of dorsiflexion would be looking at talar-crural anterior to posterior glide, so an AP glide. So stabilizing the mortise, we then want to look at how much posterior glide that talus has. So we can either use our second met head, or we can use our thumbs, trying to get more of a lateral directed or medial directed. Right? We can also do this with the knee a little bit bent to then identify the amount of dorsiflexion while taking the calf out of it. We want to make sure that if we take it to the end and they feel it, we ask them where, because it could still be the soleus in the back or the talocrural joint if they feel more anteriorly. For treatment to improve ankle dorsiflexion, right, there's a study that looked at how much is needed to show a significant change and to maintain that. And the article suggested that 2 rounds of 2 minutes of talocrural distraction, so they only do in grades 2s and 3s, so not grade 5s, 2s and 3s, 2 minutes, rest a minute, and then 2 more minutes, followed by 4 rounds of 2 minutes of talar posterior glides. So scoot up just a tad, perfect, right? And then doing an anterior to posterior talar glide. So 2 minutes, relax a minute, 2 minutes to 4 rounds. So a total of 12 minutes of manual therapy, and then that showed a significant improvement in dorsiflexion, improvement in talocrural mobility that they're able to sustain for some time. Following your manual therapy to the talocrural joint, you can follow it up with contract, relax, stretching to also improve that new mobility you just gained. So if you're doing this, have the patient push into my hand, push, 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 and let it go. And then follow it up with a forceful dorsiflexion stretch. If they feel it more in the calf, and you're trying to get it to feel more in the joint, you can place a small wedge under the knee to again add a little slack to the gastroc. Right? So again, push into my hand, push, 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 and let it go. And lean into there. Good. So again, we just spent time improving joint mobility. Now we're passively taking it to end range to help improve that further. Another way to improve dorsiflexion is through stretching soft tissue or foam rolling. And there's a study that came out that compared, right, the normal calf gastroc stretch, so leaning against a wall, compared to foam rolling the muscles. So go ahead here in long sitting, right, weight bear on the involved leg, and then roll it back and forth. This can also be done sitting in a chair or standing using a smaller foam roll the foam. The nice thing was both groups, the stretching group and the foam rolling group, both improved mobility in the dorsiflexion. So that was the goal. However, the benefit of foam rolling over the stretching was there was no loss of power or torque. Actually, power improved in the foam rolling group where it decreased a tad in the static stretching group. So prior to performance, maybe we choose to roll it out or stretch it out. For patients to further improve dorsiflexion at home, they can use a SelfMWM strap or a belt placing around the anterior ankle. They can do this in kneeling or with their foot on a stool or step. Right? The band or belt goes in a posterior and inferior direction. Then they just lunge forward. Right? So it's kind of like a SelfMWM using a belt or a band. The last thing we'll talk about is a taping job that helps improve dorsiflexion as well. Right? It's a modified MWM tape job. They had patients walk as well as measure passive dorsiflexion, and then they apply the tape in with their foot on a stool or a step in a lunge position to go to dorsiflexion. They place the tape on the lateral part first, applying it to the calcaneus, adding max tension and going from lateral to medial, and then reattaching to the calcaneus. Right? So this adds a relative posterior-inferior glide to the talus. Right? Next, they had the patients just walk for 5 minutes, and then remeasure dorsiflexion as well as gait kinematics. And the nice thing was, after that taping job, improved mobility. Hope you guys learned stuff about dorsiflexion today, how to assess and treat it, and please go to PhysioU to learn more. Take care.